we've talked about treatment. We've talked a little bit about those who are high risk. We can give all of our patients great treatment, and then we're on the other side in survivorship. And just like Dr. Gillespie-Bell said, women suffer in silence. We notoriously do that. We take care of everyone but ourselves, and we ignore, ourselves repetitively. Even for our breast cancer survivors, they don't have to suffer. I'm pleased to introduce Shawn Morron, who we work in collaboration with our breast and GYN onc team. She is an APP with the GYN oncology group at University Medical Center. She really is our go-to person to be able to help women on the other side of their treatment who we are giving life-saving treatment to, and tell them that they have to be on it for 5 years or 10 years, or that their ovaries have stopped functioning, and they think that we don't care, but we do, and we should. They are suffering in silence. She is the head of our Garnet Clinic. Don't ask me what the acronym is, totally. But it really is our clinic, our partnership clinic at University that sees women who have any female cancer and who have symptoms and side effects, and really focuses in on what women are feeling. Like Dr. Gillespie-Bell said, they won't talk about it, but we make them talk about it. We ask the questions, are you having this? And give them a safe space in order to tell us their symptoms so we can help them. So Dr. Morron is gonna let us know what is safe. And also sometimes as medical oncologists, you all don't want to prescribe some of these medicines for your patients with breast cancer because you think it's going to counteract what's happening with their breast cancer risk. But Shawn is going to tell us that it's okay.
Well, we'll balance that.
Somewhat.
Thank you. Thank you, Dr. McKinney. I might need help. Oh, here we go. I got it. Yeah. And then where are the, okay. Oh, here we are. Okay, yep. Awesome. Thank you, Dr. McKinney, for the introduction, and I'm honored to be back here at CAGLA speaking. Thank you, Dr. Gillespie, for laying the foundation. There's going to be a lot of redundancy probably here today, but I'm really going to focus on our female cancer patients. I don't have any disclosures. So the elephant in the room now after that talk is, should we use hormone therapy in our breast cancer survivor patients for the treatment of their menopause symptoms? And just like everything in medicine, it's a balancing act between the risks and the benefits and having these shared decision-making discussions with our patients. Women's Health Initiative in 2002, what it did is it stopped real discussions about menopause between patients and clinicians, and women began to suffer in silence. And as was said before me, in November of 2025, the FDA lifted the black box warning for estrogen products in the use of menopause hormone therapy. And now we're in a menopause revolution, and you get estrogen, and you get estrogen, and right? And that's where we're at. Our professional societies were out in front of this, and 3 days after the Health and Human Services announced this, ASCO put out a statement, and in their statement they said systemic hormone replacement therapy remains contraindicated for women who previously had breast cancer, particularly those with hormone receptor positive disease, and also other estrogen responsive cancers due to the increased risk of recurrence. However, low dose vaginal estrogen remains a good option for those survivors whose genitourinary symptoms do not respond to non-hormonal treatments initially. And of course, this should be done after having a discussion about relative risk and benefits with an oncology professional. So why does this discussion matter? Well, it really matters because we know that our patient population that we treat, female cancer survivors, their menopause symptoms are often more severe. This gravely impacts their quality of life. We also know that there's conflicting messages out there amongst media outlets and between clinicians themselves. Our breast cancer patients are now on longer treatments, more complex endocrine therapies. This can cause adherence consequences, so up to 25% of our breast cancer patients will often stop their endocrine therapy due to the side effects. And then, of course, patients can also go online and get estrogen products. So it's really important that we're having these informed conversations with them so that they're not just going out there and getting, what was told by them on Instagram to get, and then it's a risk to them. So this discussion, this menopause discussion with our patients really does matter. Breast cancer is not a monolith. Every patient's needs differ, and the treatments must be individualized. SGO also put out a statement after the removal of this black box warning. Basically in our GYN cancers, I won't spend a lot of time, I do work in gyn-onc, so I do want to talk about gyn-onc a lot, but basically in our gyn-onc clinic, we are starting to prescribe hormone therapy for these symptoms in our lower risk patients. We are not giving it to our advanced stage endometrial cancer or uterine sarcomas, nor are we giving it to our low-grade serous or endometrial ovarian cancer patients. The AUA also put out a statement, and just kind of focusing right here for the sake of time, the middle one here. So the AUA said for GSM symptoms with patients that have a personal history of breast cancer with GSM symptoms, it's recommended that we use low-dose vaginal estrogen, but using a multidisciplinary shared decision-making model. More recently, in January of this year, there was a comprehensive review looking at the current evidence of menopause hormone therapy amongst breast cancer patients, and Glenn and Associates put together a 25-member multidisciplinary panel, and the panel consisted of 18 physicians across various specialties. They reviewed the current evidence relating to the use of vaginal and systemic menopausal hormone therapy. And based on the available data, the consensus is that shared decisions be based on an individual's menopausal symptoms and impact on quality of life, the potential increase in an individual's risk of relapse by use of menopausal hormonal therapy, and patients' preferences, views, and treatment goals. Also, at the end of last year, there were 2 systemic reviews and meta-analyses that looked at recurrence data with our vaginal hormone use and breast cancer survival, and both of these reviews concluded that there was no significant increase in cancer recurrence among our breast cancer survivors when using vaginal estrogen therapy to treat their symptoms. This is kind of a table that really looks at the different studies that were reviewed in that data. And I did want to highlight one of the studies that can cause some controversy or that people talk about is the Danish study that came out in 2022. This was a large cohort of postmenopausal Danish women with invasive non-metastatic ER-positive breast cancer that were diagnosed between 1997 and 2004. They did a stratification by adjuvant endocrine treatment and found that women that were on an AI had an increased risk of breast cancer recurrence if they were on vaginal estrogen. However, the same study found that there was no increase in women who were using systemic estrogen, which I think is interesting. I do not believe that this study should be practice changing or deter us from using low-dose vaginal estrogen, and the reason why I believe that is because that the women that were included in this study, this was done during a time when it wasn't reported that there was any HER2 expression or molecular signature testing. So it was very hard to stratify how high risk these women were. Also, the type and standards of endocrine therapy have changed since that time, and the type of vaginal estrogen. So in this study, in the Danish study, the vaginal estrogen that they were using was a very high dose of 25 micrograms. That's not what we're using now. We're using lower doses of vaginal estrogen. So ultimately, I think what this study, the Danish study, tells us is that we need to continue to personalize our approach to our patients, weighing all of the factors that we've been discussing. So implications of estrogen exposure. So from the standpoint of or regarding systemic hormone therapy in our patient population, this is generally avoided or it's used with extreme caution in our ER-positive patients, regardless of their surgery type. Mastectomy does not eliminate the systemic risk of recurrence. Local and vaginal estrogen for GSM symptoms there's increasing evidence that supports careful shared decision-making with its use. Surgery type plays less of a role than recurrence risk, time of diagnosis, and ongoing endocrine therapy. So we've looked at the literature showing no increased risk with low-dose vaginal estrogen. We know what the recommendations from our professional societies say now. But maybe you've never prescribed local vaginal treatments or you're not comfortable with the signs and symptoms that patients may present with. So I just want to spend a little bit of time talking about that today. It does start with knowing that we can make a difference when we validate and listen to women for the purpose of improving quality of life, extending outcomes, preventing long-term consequences, and really empowering women through education. Because menopause is survivorship care, and these discussions will not happen in 5 or 10 minutes. When we open this discussion up to our patients, it is important to know that the indications for hormone therapy, this is based on the Menopause Society's most recent position statement where they're looking at indications for hormone therapy in average risk women. And these guidelines do recommend that we use caution with estrogen in our breast cancer survivors. But of these 4 categories, we're going to cover the GSM. Today more closely. The Menopause Society statement says that there's random controlled data and evidence for restoration of GSM anatomy, reduction in pH and symptoms of GSM, an increase in superficial vaginal cells for women that are just having symptoms related to GSM, and that we can just treat locally. So what exactly is GSM? Thank you for asking. So many of you probably know all of these symptoms, but just as a reminder, as we keep our patients in the center, oftentimes women will experience dryness, lack of lubrication, as well as that infamous vulval vaginal atrophy or changes to the vulval vaginal tissue. This is why I really do like the term GSM better, because it acknowledges that it's not just the vagina and the vulva, but also many women have urinary symptoms and recurrent UTIs. It also includes sexual dysfunction, and we know that sexual health is health, and this is an important quality of life a factor for women. All of these symptoms can be subjectively reported by patients, but what are the objective findings when your patients come and say they have these symptoms? So objective findings are going to come from doing an exam. I realize that not every clinician feels comfortable with doing a pelvic exam. But I assure you, we were all trained to be able to do pelvic exams, and we all can do them. They're within the scope of our practice, and you're not going to break your patient by doing a pelvic exam, even if you don't have a lot of experience doing it. It actually is going to give you valuable information to help have those shared decision makings and guide your treatment if you can get those objective findings. So what are you going to see if you do a pelvic exam? Oftentimes you'll see stenosis or narrowing or shortening of the vagina. The vagina tissue is going to be a little more, there's going to be some hypopigmentation, a loss of rugae, thinning of the tissue, sometimes thinning of the hair. You'll see microfissures in the vagina, and there's going to, the vaginal pH usually increases. You might see like a yellow, like stringy discharge that's not really consistent with BV. There's fusion of the labia minora. The urethra becomes more prominent. Everybody's faces are cringing, but these are the things that women are suffering with, and this is what you find on exam. This is true. Oftentimes the cervix becomes flush with the vaginal apex, and we really need to be, proactive about this, because the fallout of GSM is that these symptoms are chronic and progressive. They get worse when not treated. And it leads to painful intercourse to the point where women stop being intimate and they just stop having sex with their partners. There's a downstream effect with issues of self-confidence and self-esteem, relationship breakdowns. So it's not just the GSM. This is a much bigger for women, and sexual health is really a really important part of their overall health. So we need to encourage women to treat this right away. There's nothing wrong with women. This is just physiologically what is happening, and we need to support them and be proactive. So as mentioned, 70% of breast cancer patients experience GSM, and more than 50% of them experience sexual dysfunction, with dyspareunia being the most common complaint. Younger patients, these symptoms are often more severe and they're at higher risk. There are barriers to personal and systemic. The barriers are both personal and systemic for clinicians and patients due to limited data, time constraints, lack of comfort with the topic, and as was previously mentioned, up to 75% of patients want their clinicians to initiate these conversations. So my recommendation is in your survivorship clinics to have maybe a menopause screening tool that patients can, check the box of these symptoms, and this will open up the discussion and allow you to screen for these symptoms and get that conversation going. I'll briefly touch on this, but some of the GSM therapy options obviously are non-hormonal. We have vaginal moisturizers. I always tell patients these vaginal moisturizers are something that you want to use every day, like you put moisturizer on other parts of your body. You're going to just do that in your vagina every day. And the more consistent you are with it, the better outcomes you're going to be. These moisturizers are not used for intercourse. We have lubricants for that, and I always counsel patients, even if they're on vaginal estrogen, to still use copious amounts of lubrication during intercourse to reduce that friction. Some of the pharmacologic options are vaginal estrogen, vaginal DHEA, and ospemifene. It's important to know that no one medication, including hormone therapy, is enough to fully optimize midlife health. Just briefly, DHEA, these are vaginal suppositories that have been shown to work great for GSM and treating dyspareunia. In the studies, the serum steroid levels were within normal postmenopausal range, and there was no change in the endometrium. So just a note, with all of these vaginal topical therapies, you don't need a progestin to protect against endometrial cancer like you would if you were using systemic hormone replacement and they had a uterus. Important to know that the data here with DHEA is limited in breast cancer survivor, but there are some trials looking at women who have survived breast cancer and are on an AI that DHEA is both effective and appears to be safe. Another pharmacologic option is the ospemifene, and really what I'll just highlight on that is that that's not approved for use in breast cancer survivors in the US. But it is approved in Europe, and they're using it in breast cancer survivors in Europe. So that's probably just important for us to know, because our patients might be hearing this, on social media or through media outlets, and we want to make sure that we're giving them informed decision, letting them make informed decisions. So some of the different formulations of vaginal estrogen, we have various different types of low-dose vaginal estrogen. There are rings, creams, inserts. Systemic absorption varies by formulation, so the NCCN recommends these bolded or highlighted options for consistent dosing and lower systemic exposure. The ring, the tablet, and the insert, as you see here. I did want to point out that the ring, the 7.5 microgram ring, the brand name is East String. That's for local use. The other 2 rings that you see here at higher doses are for systemic use. All right, so let's talk about what estrogen does for the vulvovaginal area and why we will probably see better benefits from local estrogen use for these symptoms than we will with the non-hormonal. So basically, vaginal estrogen reverses all of these symptoms that come with menopause. It lowers the vaginal pH, it increases the proportion of superficial cells and decreases the proportion of parabasal cells, thickens the epithelium, increases rugae and elasticity, increases vaginal secretions, vibratory sensation, and it alleviates the subjective dryness, itchy, and irritation complaints that our patients have. When counseling patients, it's important to use these principles and approaching the conversation from an evidence-based standpoint and not a fear-based standpoint. We always discuss risk versus benefits, helping our patients make a decision they feel good about while taking into consideration their values and goals. Using informed consent and allowing for patient autonomy. I do believe women have a lot of wisdom when it comes to their bodies and how they feel, and I believe that if we present women with all the data and all the information, they can make a decision for their bodies that they feel really good about, and really that's the essence of patient autonomy. A few pearls when treating GSM. So for our high-risk patients, you always want to start with aggressive moisturizers, some of the non-hormonals that we talked about. The more proximal vagina, or the upper third of the vagina, is where the highest absorption is going to occur. So for our high-risk patients, it might be more beneficial for them to use cream around the introitus or the distal vagina. And along those lines, our patients who are having pain with insertion during sex, estrogen could be beneficial when applied to the introitus. And then always, it's very important that if these patients are complaining of vulvovaginal symptoms and the symptoms are progressive, that we consider biopsying it, because a lot of our vulvar cancers and other etiologies start with itching of the vulva. So it might just not, it might, you know, we don't want to miss a secondary cancer, pretty much. Key takeaways, so first-line treatment in our female cancer survival should be non-hormonal options. Low-dose vaginal estrogens and vaginal DHEA can be considered for many with GSM. Also to note, low-dose vaginal estrogen and vaginal DHEA are systematically absorbed in a dose-dependent manner, with the serum estrogen levels being maintained within a postmenopausal range. Breast cancer and menopause is not a one-size-fits-all. These discussions require a collaborative approach because they're very nuanced. Patients have differences in their personal values, individual risks, and their tolerance of uncertainty. And hormone therapy, whether it's systemic or vaginal in our breast cancer patients, should not be a hard no without having a valuable discussion with the patient first. I wanted to plug the San Antonio Breast Conference of this last year, because they did an entire session on hormone replacement therapy in breast cancer patients, and they do have a YouTube channel, and I highly recommend that. References, and thank you so much for having me.
That was great. Thank you so much. And we basically stayed ahead a little bit on time. So I appreciate all of the speakers. If you have questions for any of our speakers, please raise your hand, yell out, let me know. Yes.
To the last part of the panel, much discussion about progesterone would be very well received by me and the audience, please.
Okay, discussion on progesterone. Is this mic working? Yeah. Okay, thank you.
Thank you. It works better if you turn it on a bit. Okay. So for progesterone, well, when we're doing hormone replacement for women that still have a uterus, we always have to balance the estrogen and progesterone, because if you give unopposed estrogen, then it can lead to endometrial cancer. For women that are having difficulty sleeping in their perimenopause, again, what I was saying earlier, micronized progesterone is the one that's the closest to what our body naturally makes. And so for a lot of my patients, they may not have hot flashes, night sweats because they're perimenopausal. So we do prometrium at night because it makes you sleepy, and it definitely helps with sleep. Did that answer your question?
And how do you monitor the levels of all of these hormones once therapy has been initiated?
So that's a great question. I generally, in the recommendation from ACOG, we don't monitor any levels. All the time I have patients and they're like, I think I'm in menopause. Can we check my hormones? And I say, well, what hormones do you want to check? Because if you're in perimenopause, hormones are doing this. If you've had a year with no periods, then your hormones are this. So we don't need to check any blood levels. And we generally don't check for even once women are on hormone replacement therapy, because we're managing based on symptoms.
Yes, sir.
So, part of this conference has been about decision medicine, and a lot has been about data. And as a musculoskeletal physician, there's benefit beyond the menopausal symptoms from both estrogen and progesterone on supporting the musculoskeletal system throughout life. And data is important. And so, when we look, so we have women who, they get breast cancer, even men, there's a range of what we see in, patient body habitus. So if we're going to talk about data, we should be checking hormone levels. And part of it, the problem with the blood is that it's kind of not truly as specific as what we use, which is saliva. But if you happen to have, say, extra fat in your body, you are going to convert DHEA to estrogen. So without knowing what the estrogen level is, and then giving estrogen as a therapeutic, thing, you're adding to the estrogen, and you could possibly be adding to increasing the risk of getting breast cancer. And the natural downregulator in the body for estrogen is progesterone. So whether you have a uterus or not, if you want to give estrogen, you should complement estrogen therapy with progesterone.
Do y'all want to start that first or no?
Everybody has
Should I? Yeah.
That may be what the musculoskeletal literature says. That's different than what the American College of Obstetricians and Gynecologists and the North American Menopause Society recommend.
Yeah, I mean, even without measuring hormone levels consistently in the body, the data does show that it does not increase our breast cancer risk. Now, there are other risks for breast cancer that we counsel patients on that they have the power to reduce: obesity, alcohol, smoking, all of those things. So this is not done in isolation, but it's done in congruency with other things that you need to do as a whole to reduce your risk, not only for breast cancer, which you may be at a lower risk of than health disease because of your obesity, or other cancers. So again, a collaborative, a multifaceted type of discussion I feel is important. And all too often, those conversations are not happening, one, because physicians, unfortunately, don't have time to have those discussions. But it can be done with your nurse practitioner or APP when you have a team where that's important. So I'm all for, a collaborative care for the patient, but these things are not, although we're focusing on hormone replacement, we recognize that we take the patient as a whole in totality, and things that can be done to reduce their risk, those things are also discussed and should be as a part of their total care.
I will add that the data that we talked about here today in our breast cancer survivors, there's limit in what is the risk of using hormone therapy to treat these symptoms. There's limited data, and the data that we have is not long-term data. So it does need to be studied more, but we do have enough to feel comfortable in improving the quality of life for women, because we know that their outcomes are actually not as good when they're suffering from these symptoms. So we do know that, and we have data, you know, along those lines. And so I would rather my patient, we would rather, you know, and I think the professional recommendations out there are considering this, that we would rather our patients have better quality of life during that survivorship period, because that does lead to better outcomes, than to be suffering and potentially quit their long-term therapies, their endocrine therapies, things like that. But to your point, we do need more long-term data that looks at this, and I think that we're getting there to that point where we're realizing this is important and we need to study this more.
I think just to echo that, I'm so glad that these conversations are happening. I do think we're seeing more of this, unfortunately, or maybe fortunately, on social media. But I think also here in data, I mean, you know, I have patients now coming and asking, okay, you're giving me an aromatase inhibitor. What is this doing to my long-term risk for osteoporosis? What about, is there a risk of dementia? Is that, you know, I think patients are more tuned into these side effects. And I think on our end, just making sure we're asking the questions, asking about vaginal dryness. I promise I do try to make a point to ask about that, because patients often, as you mentioned, are really not going to lead with that. So making sure we're asking the right questions and really having informed discussions with them about the risks and benefits. Sort of the line I use is, you know, I never want the prevention of a breast cancer that may or may not ever come back to bother you to make your quality of life terrible, because otherwise, you know, what's the point? That's not to say I'm obviously not encouraging hormone replacement therapy, but certainly using things like vaginal estrogen and things that we know have been shown to be safe in these patients is important.
Yeah. Any other? The question is, any comment on the Mona Lisa trial? Is that what you're, oh, Mona Lisa procedure. That may be a Gillespie Bell question.
I know I have.
We do have a Mona Lisa restaurant.
Okay.
Sorry, I went straight
It's
to
not-
trial mode.
It's not a procedure that I perform. I think there's a little bit of data out there on that, but it's not a procedure that I perform. I don't know if you want to. Did you have more? Or,
I've got very little experience with it. I just thought, you know, I don't have any experience with it.
What? Prolapse? Okay. Okay, all right. See, I always tell patients I'm from here to here, so like procedures that are lower than that, I'm not well versed on. So, but Dr. Gillespie Bell has informed us that it is a procedure for vaginal prolapse to lift and tighten, which can happen, you know. Yes, Urogyne. Yeah, I'm sure that you all see that in the gynecological realm, and that can be a certain contributor to a lot of the symptoms that patients can have just as a result of aging.
yeah, I mean, and typically, what the data has shown to benefit for those patients, because that is true that once they're starting to go into menopause, in addition to having atrophy, you can also have some pelvic organ prolapse, especially if they are women that had children, not even delivered them vaginally, just carried children, then they do have an increased risk for that. One of the first things that we do recommend for that is vaginal estrogen. And actually in a head-to-head study between DHEAS vaginally and vaginal estrogen, DHEAS does better for actually bringing moisture and repairing the tissue, making the tissue thicker. So we usually recommend that, and starting with pelvic floor physical therapy, those things have been shown to help, not just for incontinence, but just even that sensation that things are starting to fall.
Thank you. See, I'm learning all kinds of new things. Any, yes, miss-
Hello, my name is Destiny. I'm a senior biology program manager at Xavier. Okay, this could be more of a plastic surgery question, but when it comes to breast implants and, women that survive breast cancer and really have that as your reconstruction option, after the second, has anyone looked at the use of estrogen and how that would affect that reconstruction option, estrogen or any other hormone replacement therapy?
you want me to talk about? So after we do mastectomies and patients have reconstruction, it's not the implant that is the issue, right? Even with mastectomies, the risk of recurrence with breast cancer doesn't go down to zero. Nothing's 100% or zero in medicine, right? So you still have a risk of breast cancer if you have a breast cell that is left after the mastectomy under the flap. So it has nothing to do with the implant or where the tissue is taken from. It can be taken from the belly, the back, the thighs, the buttocks, whatever. That's not the tissue that could develop into a recurrence. It's the potential tissue that is left underneath the skin for a cosmetic reconstruction that has the potential to develop into breast cancer. That risk is still low with mastectomies, whether patients are, on hormone therapy or not, hormone replacement therapy or not. It does not affect the implant. The hormones don't have any effects on the implant. Is just a plastic piece of or silicone or no, it doesn't. Doesn't affect that. It's not tissue. Yeah. Any other questions? All right, we have 3 minutes for you all to get ready for the crawfish boil. Thank you so much for attending. We'll see you next year.